Everyone. Today we are going to discuss about neoplastic diseases of the ovary. However, because you have already discussed benign tumors of the ovary, today we are going to focus on ovarian cancer, although we still have to touch on some benign tumors of the ovary. So let's review with the anatomy of your reproductive organs. So I hope you still remember them. So this is your uterus. Okay, and you have your two ovaries on the sides. And this is your fallopian tube. It is very important for you to remember the relationship between fallopian tube and the ovaries, since currently it is believed that fallopian tube cells play an important role in the development of ovarian cancer. So these are gross pictures of an ovarian tumor. Would you be able to differentiate or identify grossly which one is malignant? You still remember your anatomy. So this is your description about tumors of the ovary. So this one has a very smooth surface and it seems to be unilocular. On the other hand, this one is also has a smooth surface, but however, it seems to be multiloculated. So I hope you still remember what are the characteristics between benign and probable malignant ovarian tumors, so that you'll be able to more or less grossly identify which one is probably malignant and which one is probably benign. So this is the WHO classification of ovarian neoplasms. So the most common class of or type of ovarian neoplasm is your epithelial, or what you call epithelial ovarian tumors. Then the second most common would be your germ cell tumors, followed by your sex cord stromal tumors. So we'll have to differentiate them later on. So lipoid and your gonadoblastomas are rare ovarian tumors. If you still remember, I mentioned earlier that there are usually two types of ovarian tumors. They are either benign or malignant. However, you will learn later on that there is actually a third type of ovarian tumor when we talk about epithelial ovarian tumor. So when you say that the tumor is benign, or it usually ends with oma, like your serous adenoma or mucinous adenoma. On the other hand, if it is malignant, the terminology used is commonly serous adenocarcinoma or mucinous adenocarcinoma. The major cell types of ovarian epithelial tumors recapitulate the Mullerian duct-derived epithelium of the female reproductive organs. So, considering all of our epithelial ovarian tumors in general, so the most common type of epithelial ovarian tumor is serous, followed by mucinous, and you have your endometrioid. Clear cell and Brunner tumors are usually rare. However, if you talk about malignant ovarian tumor, so ovarian cancers, the most common is still your serous adenocarcinomas. The second most common would now be your endometrioid adenocarcinomas. And the third most common would be your mucinous adenocarcinomas. You will also see that clear cell carcinomas are quite rare in a benign form. However, they have a higher incidence among malignant ovarian tumors. I mentioned earlier that there is actually a third type of ovarian tumor among epithelial groups. And this is what you call your borderline tumor of the ovaries, or a typical proliferative tumor of the ovary, or most popularly known as ovarian tumor of low malignant potential. So if you classify now as to probability of malignancy or benign condition, so you have three types of epithelial ovarian tumor. So you have the benign form, you have the borderline or ovarian tumor of low malignant potential, and the ovarian cancers. So let's talk first about epithelial ovarian tumor of low malignant potential. So these are tumors or epithelial ovarian tumors with histologic and biologic features intermediate between clearly benign and clearly malignant ovarian neoplasms. And the most important characteristic here should be that the malignant cells do not invade the stroma of the ovary. So it constitutes approximately 15 to 20% of epithelial ovarian cancers, and they usually behave as a slow-growing ovarian tumors compared to your invasive or ovarian carcinomas. So these are the histologic criteria for the diagnosis of borderline ovarian tumors. 1. There should be stratification of the epithelial linings of the papilla. Secondly, there is formation of microscopic papillary projections or tufts arising from the epithelial lining of the papillae. And on microscopic evaluation further, you will see that there is epithelial pleomorphism, the cells are atypical, and there is increase in the number of mitotic figures. And as I mentioned previously, there should be no stromal invasion, because the presence of stromal invasion would now classify your tumor as an invasive ovarian cancer or a carcinoma. Using this histologic criteria, you at least need two of these features to make a diagnosis of borderline ovarian tumors or ovarian tumors of low malignant potential. So this is a microscopic picture of borderline ovarian tumor. So what is important, as I mentioned earlier, is that there is no invasion of the ovarian stroma, and your tumors are in several layers with papillary projections. But the most important is there is no invasion of your ovarian stroma. So the most common varieties of borderline or tumors of low malignant potentials are serous and mucinous. And what is very significant is that they are usually found among younger women. And that is very important in terms of discussion of management later on of ovarian cancers and particularly borderline tumors of low malignant potential. So the most common management or the usual management of ovarian cancers in general is total abdominal hysterectomy with bilateral salpingo-oophorectomy. However, since we mentioned earlier that most borderline ovarian tumors are found in younger women, these women might still be desirous of having pregnancy or reproductions, and therefore it is very important that you consider the possibility of not removing the uterus and the contralateral ovary, but just performing a unilateral salpingo-oophorectomy for as long as the patient satisfies the criteria for what we call conservative management of borderline ovarian tumors. As I mentioned previously, the standard management of borderline ovarian tumors is still total abdominal hysterectomy with bilateral salpingo-oophorectomy and staging laparotomy. So just remember that you can perform a conservative treatment consisting of unilateral salpingo-oophorectomy if the patient satisfies the following criteria. 1. The tumor is confined to one ovary. Okay, that is stage 1A ovarian tumor. Extensive histologic sampling of the tumor confirms it to be borderline. Contralateral ovary or the opposite ovary grossly appears normal. And the biopsy specimen of areas of the omentum and peritoneal nodularities are negative of tumors. And lastly, result of peritoneal cytologic examination is negative for malignant cells. So if this is satisfied, then a unilateral salpingo-oophorectomy or removal of just the affected ovary can be performed, and you can allow your patient to get pregnant and satisfy her desire for reproduction. In advanced stages of borderline ovarian tumors, that means higher than stage 1A, or what you call stage 1B and above, then the standard treatment is complete surgical extirpation of the tumor, and that involves total abdominal hysterectomy with bilateral salpingo-oophorectomy. So even if it is maybe confined to an ovary, but the involvement involves both ovaries, then you still have to perform your total abdominal hysterectomy with bilateral salpingo-oophorectomy, followed by pelvic lymphadenectomy, tumor debulking, and then extensive sampling of the peritoneum or the omentum so that you can properly stage later on the disease after your surgical intervention. The role of chemotherapy in borderline ovarian tumor is still considered controversial. So borderline ovarian tumors also have higher survival rates compared to your frankly invasive ovarian carcinomas. So the 5-year survival rate of all stages of borderline ovarian tumors is about 97%, and the 10 years survival rate of all stages is 89%. This is way above the survival rate of invasive or frankly malignant ovarian tumors. So now let's go to ovarian carcinomas. So this is actually the meat of our discussion today, which is particularly malignant tumors of the ovary. So ovarian carcinomas are the second most common gynecologic cancer. Worldwide, it is less common than endometrial cancer, but more common than cervical cancer. In the Philippines, however, it is second to cervical cancer, but more common than endometrial cancer. So this is more or less the statistical data based on the Philippine Cancer Facts Estimate of 2015. So in the Philippines, ovarian cancer is the 5th leading site among women, the second most common among gynecological cancers, which I have also mentioned previously. And if you consider both males and females, it ranks about 12 overall. In 2015, the Philippine Cancer Facts and Estimate mentioned that there will be about 2,657 new cases of ovarian cancers with 1,610 deaths. Incidence of ovarian cancers starts to rise steeply at age 40. So you may say that ovarian cancer is a disease of women in the 5th decade or older. This table shows to us the incidence of cancers in women based on the Philippine Cancer Facts and Estimate of 2015 and the Globocan report of 2012. So if you will see, by incidence, the most common cancer in women is breast, followed by the cervix, and your ovary is number 5, cancer of the ovary is number 5, and cancer of the uterus or endometrial cancer is number 8. However, in terms of mortality, breast is still number 1, followed by the cervix, but now number 3 is the lung, followed by your colorectal cancer. Then you have your liver, the leukemias, and the ovary. So it is less lethal than maybe your cervical cancer. But because of the number of cervical cancer, it might have more deaths. But if you consider the proportion of ovarian cancer and the deaths associated with it, actually ovarian cancer is more lethal than your cervical cancer or endometrial cancer. So worldwide, ovarian cancer is the 8th most common site in women and the 18th most common overall. In 2018, it is estimated that there will be about 300,000 new cases of ovarian cancer. And ovarian cancer would constitute about the 8th most common cause of death from cancer among women during this time. So this table would show to us the countries with the highest rate of ovarian cancer. So based on the statistics, Serbia has the highest age standardized rate of ovarian cancer, followed by Brunei Darussalam, and the Philippines is number 16. So if you consider countries in Asia, then Philippines would be second to Brunei, and it may have a higher age standardized rate compared to Japan or even Singapore. So what are the theories on ovarian cancer? The most common theory is they called incessant ovulation theory. So based on this theory, the risk of epithelial ovarian cancer is directly related to the number of uninterrupted ovulatory cycles. So that means the more ovulations the woman has, the higher is the probability of that woman developing ovarian cancer. The other theory is the gonadotropin hypothesis, which is based on the exposure of the ovarian epithelium to persistently high levels of pituitary gonadotropin. It is believed that FSH promotes the growth of the ovarian epithelium to develop ovarian cancer with exposure to high levels of estrogen. So based on the incessant ovulation theory, during ovulation, the surface epithelium is ruptured and it undergoes rapid proliferation and repair. So during this process of repair, there might be invagination of the surface epithelium into the underlying stroma, which leads to the development of inclusion cysts. They are commonly called your germinal inclusion cysts. And during this process, the epithelium lining this inclusion cyst or germinal inclusion cyst undergoes transformation under the influence of oncogenes, transformation into a malignant process. So based on this theory, what type of women are at risk of developing ovarian cancer? So these might be women who have early menarche, and had late menopause. However, if you consider that there might be interruption in the lining epithelium secondary to tubal ligation and hysterectomy, then this procedure might lessen the risk of developing ovarian cancer. On the other hand, your gonadotropin hypothesis states that with increased gonadotropin levels, these high levels of gonadotropin promotes estrogen biosynthesis in the ovarian stroma, leading to abnormal proliferation of your adjacent epithelium, so that there a higher level of your gonadotropin will lead to the development of ovarian cancer. So in that instance, what are conditions that might be related to the development of ovarian cancers based on this hypothesis? So the use of your fertility pills might be associated with a higher levels of gonadotropin, so it might be related to increased risk of the ovarian cancer. And if you also will recall, with the use of your fertility pills, there might be more ovarian follicles that will be developed, so there might also be higher probability of ruptures in the surface of the ovarian epithelium, leading to development of germinal inclusion cyst. On the other hand, breastfeeding and pregnancy, or even the use of your oral contraceptive pills, prevents ovulation, and therefore might be a protective factor in the development of ovarian cancer. So this table summarizes the factors that increases or decreases the risk of a woman to develop ovarian cancer. So age, as we mentioned previously, is a factor that determines the risk of developing ovarian cancer. As the woman grows older, her risk of developing ovarian cancer increases. And if you remember, based on the Philippine Cancer Facts and Estimate, it states there that the risk or the incidence of ovarian cancer rises steeply starting at age 40. Family history, as we will discuss later on, also a very strong factor. Infertility and nulliparity might be related because infertile women are mostly maybe have lesser parity and therefore might be at increased risk of ovarian cancer. We mentioned about ovulation and ovulatory drug use. Use of talc is still controversial. On the other hand, breastfeeding, oral contraceptive pills, and pregnancy decreases the risk of a woman from developing ovarian cancer. And again, this would relate to incessant ovulation theory because these three factors decreases the number of ovulations and therefore lowers the risk of developing ovarian cancer. Tubal ligation and hysterectomy, even with ovarian conservation, has been found to decrease the risk of ovarian cancer. This is related to the current prevailing theory that cells coming from your tubal epithelium might be a strong factor that determines the development of ovarian cancer. So that if you remove the fallopian tube during the process of hysterectomy, or you perform a tubal ligation, which decreases the leakage or dissemination of tubal cells into the ovary, might lessen the risk of developing ovarian cancer. So now let's go to the different risk in details. So genetic, a strong family history of either breast or ovarian cancer is one of the most important risk factors for the development of epithelial ovarian cancer. Approximately 10 to 15% of all epithelial ovarian cancers have a hereditary predisposition. And there are three types of hereditary predisposition for developing ovarian cancer. The first type is what you call the breast ovarian cancer family syndrome, which states that the lifetime risk of ovarian cancer in women with germline mutation for BRCA1 approaches to 40%. In women with BRCA2 mutations, the lifetime risk of developing ovarian cancer ranges from 10 to 20%. So who are candidates for determination of BRCA1 or BRCA2? So these are women who have a strong family history of ovarian cancer or breast cancer. Example is if the mother has breast cancer and the daughter also has breast cancer, then their family should be investigated for BRCA mutations so that their future children, the female children, can be protected from developing ovarian cancer by performing surgical intervention. So currently, women with breast or ovarian cancer are recommended to have BRCA mutation determinations. The other group is what you call site-specific ovarian cancer. So these women only has ovarian cancer and they do not have the breast cancer that we mentioned previously. So this is linked to BRCA1 mutation, and they have found out that women in this group have BRCA1 germline mutation, but they do not manifest with breast cancer, but purely ovarian cancer. The third group is your hereditary non-polyposis colon cancer, or what you call your Lynch syndrome 2. So these women might have a strong family history or have in their family a high incidence of colon cancer, so they can be properly investigated. And if they are positive, so they can be at risk of developing ovarian cancer as well. So Lynch syndrome 2 accounts for only about approximately 1% of all ovarian cancers. So how about reproductive factors? So we mentioned previously that parity and pregnancy might be a factor. So the increasing parity of more than 5 reduces the risk. Again, this is related to ovulation because the more pregnancies you have, the lesser number of ovulations the woman will be. So the risk of developing ovarian cancer might also be lower. Age at menarche and menopause are considered weak predictors on risk of epithelial ovarian cancer. So we currently, if a woman has early menarche, or maybe menarche at age 10 or 11, that does not necessarily mean that that woman has a higher risk of developing ovarian cancer. Because if she has early menarche, but she also has early menopause, then the duration of ovulation is lesser. Or even if she had early menarche, but she has had several pregnancies, then that would also offer protection from developing of ovarian cancer. Lactation, on the other hand, confers protection against ovarian cancer, most significant during the 18 or more months of lactation. Exogenous hormones, as we mentioned previously, the use of your fertility drugs does not increase the risk of ovarian cancer, but increases the possibility of borderline ovarian tumors. And this is related to what we mentioned previously as high gonadotrophin levels. So OCP, because it prevents ovulation, is protective. Okay, so use of your oral contraceptive pills confers long-term protection against ovarian cancer, whereas long-term use of unopposed estrogen plus progestin is associated with increased risk of developing epithelial ovarian cancer. Endometriosis currently is linked to an increased risk of epithelial ovarian cancer, particularly endometrioid and clear cell ovarian carcinomas. Pelvic inflammatory disease also has a positive association with epithelial ovarian cancer. Polycystic ovarian disease is less extensively evaluated but points to increased risk of developing ovarian cancer. This may be related to the gonadotrophin hypothesis theory. And as I mentioned previously, tubal ligation confers a reduction in the risk of ovarian cancer, and hysterectomy also confers a lesser risk of developing, less risk of reduction in developing ovarian cancer. Obesity in early adulthood confers increased risk of ovarian cancer. Cigarette smoking increases the risk for development of mucinous epithelial ovarian tumors, but not other histologic type. Stopping smoking returns the risk to non-smoking levels. So that means it will be advantageous for women to stop smoking to lessen the risk of developing ovarian cancer. There is no association between moderate alcohol intake and ovarian cancer. So remember the word moderate. Okay. A diet characterized by high meat and fat intake increases the risk of ovarian cancer. Physical activity, so recreational physical activity, confers at best a weak to moderate protection against epithelial ovarian cancer. The association between caffeine intake and ovarian cancer is not well established, but the consumption of tea may reduce the risk of epithelial ovarian cancer. There was a Japanese study that found that application of talc in the perineum increases the risk of ovarian cancer. However, subsequent investigation found that there is no causal relationship between the risk of the use of talc and the risk of ovarian cancer. So this table would show to us the age-related incidence of ovarian cancer. In general, as we mentioned previously, more than half of ovarian cancers occur in older women or women older than 40. The risk of malignancy is in primary ovarian cancer increases to approximately 33% in women older than 45. But whereas it is less than 1% in women between age 20 to 45 years of age. So this table shows to us that based on the type of epithelial ovarian cancer, age is also a strong factor. So just like epithelial ovarian cancers are most common in women more than 50 years of age. On the other hand, Germ cell tumors are common among women less than 20 years of age. Your gonadal stromal tumors are also more common among women in the older age group. The symptoms of ovarian cancer is usually vague, and it is not specific for ovarian cancer. Therefore, a high index of suspicion is warranted in all women between the ages of 40 to 65 years who have persistent gastrointestinal symptoms that cannot be diagnosed, or when there is a strong persistence of gastrointestinal symptoms even with intervention that has been related to gastrointestinal pathology. So there is currently no simple way to accurately screen for ovarian cancer. So the most common symptoms that we have found related to ovarian cancer is abdominal swelling or abdominal enlargement, abdominal pain, dyspepsia, urinary frequency, and weight change. So among this, abdominal enlargement, especially associated with acidic fluid, is highly related to development of ovarian or the presence of ovarian cancer. Abdominal pain is a late manifestation, but if it is associated with an abdominal mass, then it might also be highly indicative of probability of ovarian cancer. Dyspepsia is a very common manifestation of gastrointestinal pathology. However, it can also be an early sign of impending ovarian cancer. So this is a woman who presented with abdominal enlargement, and if you inspect the abdomen, you will see that there is a mass which might be lobulated or might be two masses, and the bulging on the sides might indicate that she has ascites. So the probability of malignancy might be higher in this woman. On the other hand, this woman has a huge abdominal enlargement, and if you look closely, the flanks are also bulging, which might indicate fluid within the abdominal cavity. And if you look closely to the umbilical area, there is actually a mass there, which might point to a higher probability of an ovarian cancer. So these are the different characteristics that differentiate benign from malignant ovarian tumors. So most unilateral ovarian tumors are benign, whereas most bilateral ovarian tumors are malignant. Remember that I use the word most and not all. Cystic ovarian masses are generally benign, whereas solid ovarian masses are commonly malignant. Malignant ovarian tumor can present as well as cystic tumors with solid areas, or solid ovarian tumors with some cystic areas. So the combination of cystic and solid is more towards a malignant ovarian tumor. Mobility, or masses that are easily movable within the abdominal cavity, probably indicates a benign ovarian tumor. On the other hand, a fixed or very hard to move ovarian tumor might relate to malignant conditions. Ovarian tumors with irregular borders are commonly associated with malignant conditions. However, those with smooth surface, as we have demonstrated in the abdomen of the two women that we presented earlier, the first one, correlates more to a benign condition. The presence of ascites is a very strong determinant for malignant ovarian tumors. And if you perform a good rectovaginal examination, the presence of nodulations in the cul-de-sac or the area of your uterosacral ligaments highly correlates with development of malignant ovarian tumor. You must remember, however, that if it is in younger women, especially if it is related to dysmenorrhea, then nodulation on the cul-de-sac can also be present among women with endometriosis. So you have seen this table previously. So again, we'll now focus on ovarian cancers. So the most common epithelial ovarian cancers belong to your serous epithelial ovarian cancers, followed by your mucinous, and then your endometrioid. Or is that right? No, it is wrong. So in terms of malignant ovarian tumors, the most common is still your serous, now followed by endometrioid ovarian cancers, then you have your mucinous and your clear cell. Brainers are rarely malignant. So this is an example, a gross picture of a papillary serous adenocarcinoma. So typically, serous carcinomas occur in older women, women more than 40 years of age. And molecular investigation have shown genetic changes associated with low-grade serous tumors that supports the reclassification of serous ovarian cancer into low-grade and high-grade types. Currently, the popular theory that high-risk or high-grade ovarian tumors may arise from your fallopian tube epithelium. So this is a microscopic picture of your epithelial ovarian cancer. So microscopically, they consist of ciliated cells that resemble those of the fallopian tube, and the presence of microcalcifications, or what you call their Samoma bodies, are common findings in serous papillary carcinomas, which might be related to a good prognosis or well-differentiated serous adenocarcinomas. This, however, is a picture of a mucinous cyst carcinoma. So mucinous carcinoma usually occurs in those 30 to 60 years of age. They are commonly unilateral with smooth surface, and they are commonly diagnosed in the early stage or stage 1 disease. On cut section, they are usually shows multiseptations, and they secrete a mucin type of fluids. So on microscopic examination, so mucinous tumors consist of epithelial cells filled with mucin. These cells may resemble cells of the endocervix or may mimic your intestinal cells. And that is why in women with mucinous cyst adenocarcinomas, the appendix also has to be closely evaluated. In fact, it is a common practice to also remove the appendix in women with mucinous cyst adenocarcinomas. Clear cell tumors resembles or are neoplasms of the ovaries that resembles your mesonephric structures. The tumors range in size up to 30 centimeters in diameter with a mean of about 15 centimeters. Most epithelial ovarian tumors or a clear cell ovarian tumors are associated with paraneoplastic hypercalcemia, and therefore they should be properly evaluated for these conditions. Relationship with endometriosis is strongest among all the type of epithelial cancers, but in this age group. So clear cell carcinomas are can be strongly associated with your endometrial. Clear cell carcinomas are also called mesonephromas. They occur primarily in women 40 to 70 years of age. They are highly aggressive ovarian tumors. On cut section, it is multiseptated with thick septum, and solid priable papillary structures may be found. So microscopically, they consist of cells resembling those of your endometrium, and they contain cells with abundant glycogen, and that is why they appear as clear cytoplasm. Those with solid pattern, it is characterized by sheets of polyhedral cells with abundant clear cytoplasms separated by delicate fibrovascular septae or dense hyalinized fibrotic stroma. Endometrioid adenocarcinoma are solid tumors with cystic areas with smooth outer surface. On cut section, so they also manifest as solid with cystic areas with the cyst containing friable, smooth masses and bloody fluid. They usually occur in women at their 40s and 50s. So they may be seen in conjunction with endometriosis and other ovarian neoplasms. Most endometrioid ovarian neoplasms are carcinomas and may arise from the surface epithelium of the ovary, and they are usually multiloculated. So on microscopic examination, they are characterized by a confluent or cribriform proliferation of glands that resemble the endometrium, lined by a tall stratified columnar epithelium. Mitotic figures are commonly seen. They may also manifest with squamous elements or mixed with squamous elements. Brenner's tumor are rare ovarian tumors, and most of them are benign. Grossly, they look identical to fibroma of the ovary, and they arise from Waltard cell nest of ovarian cells. So as I mentioned previously, most of them are benign, but there might be reports of very few malignant Brenner's tumor, which is associated with endometrial hyperplasia. The transitional epithelial cells of Brenner's tumors is characterized by a relatively uniform population of stratified cells with ovoid nuclei displaying clear grooves, which is named as your related to the uroepithelium, and they are called as coffee bean cells. So the characteristic findings, they look like coffee bean, So if you see this microscopic picture, then they are usually related to Brenner's tumor. Brenner's tumor can undergo uh, cystic degeneration, and they may present or they can be mistaken with mucinous tumors of the ovary. Several screening tools has been tried for early detection of ovarian cancers. However, there has been no screening test currently that is considered for early detection for ovarian cancers. Periodic pelvic examination has been tried, sonographic evaluation, and the use of tumor markers or biomarkers has also been tested. So, routine pelvic examination can detect only about 1 ovarian cancer in 10,000 asymptomatic women. On the other hand, routine laboratory tests are of no great value in the diagnosis of ovarian tumors. The major value of laboratory tests in ruling out other pelvic disorders has negated the use of these laboratory procedures as a screening tool for ovarian cancers. So currently, it is only surgical exploration that is considered as the ultimate tool to determine the nature of an ovarian tumor present. So what are the different tumor markers that has been used in ovarian cancer? So the most popular is your carcinoma antigen CA125. There is your human epididymis protein 4 or HE4, carcinoembryonic antigen or your CEA, which has been utilized as well to screen for gastrointestinal tumors, your alpha-fetoprotein, lactic dehydrogenase, and human chorionic gonadotrophin has been identified in germ cell tumors. So let's talk about CA125 and ovarian cancer. So this is the one that is frequently requested even by laymen when they talk about ovarian cancer. So CA125 is expressed in approximately 80% of ovarian epithelial cancers. However, it is less frequently found among mucinous tumors. So in that regard, it is commonly, or it will be helpful if you request CA125 in serous, endometrioid, and clear cell. But it would not be very helpful if you request it in mucinous tumors. You must also remember that CA125 is also increased in tubal, endometrial, lung, breast, and pancreatic cancers. It may even be increased in benign conditions. So the specificity of requesting CA125 appears to be better in postmenopausal patients, basically because the benign conditions that we mention here are usually not found anymore in postmenopausal women. So these are the conditions or benign conditions that can elevate or increase the levels of your CA125. So you have your endometriosis, peritoneal inflammation or your pelvic inflammatory disease, even your leiomyoma in pregnancy may have an elevated CA125. Hemorrhagic ovarian cyst also has an elevated CA125. And even your liver disease can have an elevated CA125. So in endometriosis, PID, myoma and pregnancy, or even your hemorrhagic ovarian cyst, they are common among premenopausal women. So they are rarely found in postmenopausal women. We know that endometriosis become silent when the woman reaches menopause because their level of estrogen is lower. The incidence of PID also decreases in postmenopausal women, so that it would be very helpful if you use CE125 or request for CE125 in postmenopausal women rather than in reproductive age women. So what are the diagnostic tools that are utilized in ovarian cancer? So a complete physical examination is always advisable. So you examine the abdomen of the patient. You take note about mobility, the different parameters that we mentioned earlier, the presence of cystic and solid areas, the presence of ascites, and of course, the size of an ovarian tumors. After that, then you may ask for imaging studies. Or if you are highly entertaining ovarian tumor, particularly in a postmenopausal woman, then maybe your tumor marker can also be requested. However, if you are talking about or considering a germ cell tumor, then the age of the patient might not be a strong factor. So these are the different imaging studies. So you can currently the most popular is your ultrasound. So the ultrasound can give you description on whether your tumor is cystic or solid, or predominantly solid with cystic areas. Okay, you can have your CT scan or MRI in order to characterize the tumor. And as I mentioned previously, you can request your tumor markers, especially if you are dealing with epithelial ovarian tumor in a postmenopausal woman, but be careful if you are requesting it in a premenopausal woman. Colonoscopy or barium enema study are not anymore that commonly requested because of the presence of CT scan and MRI, which will give you more information rather than colonoscopy and barium enema. So ultrasound, as I mentioned, has been very helpful in defining the criteria for the diagnosis of ovarian tumor. The risk of malignancy is also determined by your ultrasound. So several scoring system has been proposed in order to predict the possibility of a malignancy. And I would like to recommend that you review these different scoring systems that is used in ovarian cancer. So we must differentiate based on these different parameters. We can more or less maybe predict highly the probability of ovarian cancer. So papillary projections with Doppler color flow positive tumors indicate more of malignant ovarian tumor. So again, these are the different ultrasonographic features or findings that indicates a malignant ovarian cancer. So tumors with irregular borders, this you can also appreciate on physical examination of the abdomen. The presence of papillations, thick septations, ascites, and matted bowels. So these are very more or less indicative, if found, highly suspicious for the presence of ovarian cancer. So this is an ultrasonographic picture of a woman with ovarian cancer, and a Doppler flow study was requested, and you will see that there are areas which has showed positive Doppler flow, and therefore this is highly indicative of an ovarian cancer. So additional studies which may be of great help when you are ruling out ovarian cancer are your CT scan, your MRI, and your PET CT scan. This will give you, your PET-CT will give you especially information on distant metastasis or a metastatic ovarian cancer. So, however, the cost of the procedure limits its usage in our practice in ovarian cancer. So what is the treatment for ovarian cancer? So the primary treatment is surgical. Okay, so surgery is the primary treatment for ovarian cancer, and that usually involves removal of all resectable disease. And that is performance of a total hysterectomy, bilateral salpingo-oophorectomy, bilateral lymph node dissection, preferably, or if not possible, you can perform a bilateral lymph node evaluation or palpation with tumor debulking in the presence of metastatic disease. We usually describe the surgical approach in ovarian cancer as a staging laparotomy. Staging because it is utilized to determine the extent of the tumor or the stage of the disease. So when you talk about staging laparotomy in ovarian cancer, you perform a mid-line longitudinal incision. That means the incision is from the symphysis pubis going up to the umbilicus or even over the umbilicus. And then after opening up, you obtain peritoneal fluid for examination, cytologic examination. If the patient has ascites, then the ascitic fluid will be collected for cytologic evaluation. If the patient do not have ascites, then you instill fluid like your NSS, and again have this examined for cytologic evaluation for presence of cancer cells. After you have obtained your peritoneal fluid, before your definitive surgical intervention, you perform a systemic exploration of the abdominal cavity. So that means you evaluate where is the tumor, whether it is on the right or the left ovary, is there other organs involved, or what is the status of the liver and the diaphragm, or the surface epithelium of the abdominal cavity. So after you have done a thorough systemic exploration of the abdominal cavity and the structures, then you perform the definitive treatment, which is total hysterectomy with bilateral salpingo-oophorectomy. If the omentum is grossly abnormal, or even if it is not grossly abnormal, but the possibility of metastasis is there, then it is always prudent to perform an infracolic omentectomy. So infracolic omentectomy is part and parcel of the staging laparotomy. After that, then you perform your lymph node evaluation, preferably a lymph node dissection, lymph nodes in the pelvic and the para-aortic areas. After you have done your procedures, especially in tumors which seems to be just localized in the ovary, then it would be also very important to perform a random biopsy of the abdominal peritoneum, because this peritoneum might look grossly normal, but on microscopic evaluation, they may contain metastatic cells. So it is very important in the staging of the disease. If there are tumors outside of the ovaries, then this should be removed in the process, which what we call tumor debulking. So as you reduce as much tumor as possible, ideally there should be no gross tumor left behind after the surgical intervention, so that your adjuvant treatment would be more effective. So I mentioned previously that the surgical intervention or surgical procedure of choice for ovarian cancer is total abdominal hysterectomy with bilateral salpingo or oophorectomy and tumor debulking. However, similar to borderline tumor or tumor or low malignant potential, then you can also perform a conservative surgery involving performing a unilateral salpingo or oophorectomy. Again, the following criteria has to be satisfied. One is the tumor is a stage 1 disease. That means it only involves one ovary. It is a well-differentiated tumor. The peritoneal fluid cytology is negative for malignant cells. Okay, the omentum and the peritoneal biopsies are negative, and the woman is young and desirous of pregnancy. So you do not perform a conservative management if your patient is already perimenopausal. Well, the chance of pregnancy is low. So ideally, your conservative management in ovarian cancer patients should only be in young patients desirous of pregnancy. So now we go to staging of ovarian cancer. Again, staging in ovarian cancer is surgical. Staging is based on the surgical findings at the time of operation and the histological findings at the time of histopathological evaluation. During surgery, systematic evaluation, as I have mentioned earlier, an exploration of the abdominal cavity should be done, and before you proceed to performing your definitive surgical intervention. So the extent of tumor involvement within the abdominal cavity should be properly investigated or evaluated. So we always again emphasize that when you perform surgery in ovarian cancer, it should be a staging laparotomy so that more or less you are able to properly stage the disease. So what are the stages of ovarian cancer? So stage 1, the tumor is confined to the ovaries. So stage 1A, the tumor is only in one ovary. The capsule is intact, no tumor on the surface, and negative peritoneal fluid cytology. Stage 1B, tumor involves both ovaries. Okay, again, the capsule is intact, no tumor on the surface, and negative peritoneal washing or peritoneal fluid cytology. Stage 1C, the tumor is limited to one or both ovaries. And stage 1C1, when there is surgical spill. What is surgical spill? That means you inadvertently rupture the tumor during the time of surgical exploration. Stage 1C2, the capsule is ruptured before surgery or tumor on the surface of the ovary. So when you open up the abdomen, if you saw that the tumor is already ruptured, you did not rupture it or it did not rupture at the time of surgery, the stage is 1C2. And it is supposed to be confined to one ovary. Or even if your tumor did not rupture, but you see tumors or papillary excrescences on the surface of the ovary, then that will also classify your tumor as stage 1C2. 1C3 is when malignant cells are found in peritoneal washing or in ascites. So the presence of ascites alone does not make it stage 1C3. The ascitic fluid should be positive for malignant cells before you call it stage 1C3. So this is a graphic presentation of stage 1 tumor. So stage 1A, the tumor is confined to one ovary. And stage 1B is the tumors involves both ovaries. Stage 1C, okay, again, surgical spill. So the tumor might be one ovary or two ovaries, regardless, but it was surgically ruptured at the time of surgery, stage 1C1, or that rupture occurred even before surgery, or there is tumor on the surface of the ovary, stage 1C2, and 1C3, malignant cells and ascites or peritoneal fluid cytology. Stage 2 is tumor involves one or both ovaries with pelvic extension. So pelvic extension, but the tumor is below the pelvic brim, or what you call the true pelvis. The presence of primary peritoneal cancer is also under stage 2. So below the pelvic brim, so again below the true pelvis, your metastatic lesions are below the pelvic brim or the true pelvis. So stage 2A, there is extension and or implant on the uterus and or fallopian tubes. Okay, fallopian tubes and the uterus is stage 2A, and stage 2B, extension to other pelvic intraperitoneal tissues. So what are the other pelvic intraperitoneal tissues? So these are tissues inside or within the true pelvis. So implants on the surface, peritoneum, within the true pelvis is stage 2B. Implants on the surface of the urinary bladder is a stage 2B disease. Or in implants on the rectum, surface of the rectum is stage 2B disease. Take note that I mentioned surface, because if it is mucosa, then it belongs to a higher stage. So remember, I mentioned surface epithelium. Okay. So this is again a gross graphic presentation of your stage 2 disease. So there is an ovarian tumor with one or both ovaries below the pelvic brim, and there is a presence of fallopian tube, or the uterus has metastases. Or again, if it is in the surface of the rectum, or surface of the urinary bladder, or surface of the peritoneum that covers the pelvic cavity, it is stage 2B. Okay, stage 3 is when the tumor involves one or both ovaries with cytologically or histologically confirmed spread to peritoneum outside of the true pelvis, or metastasis to the retroperitoneal lymph nodes. So always remember where the metastasis is in the abdominal cavity. If it is below the pelvic brim or below the true pelvis, or what you call linea terminalis, it is stage 2. Above the linea terminalis, or above the true pelvis, or above the pelvic brim, it is stage 3 or even 4 disease. So stage 3A, positive peritoneal lymph nodes and or microscopic metastasis beyond the pelvis. Stage 3A is further subdivided into A1 when there is positive retroperitoneal lymph nodes only. And depending on the number of lymph nodes, then you have, or the size of the lymph nodes, then you have stage 3A1, 1, that's I, or 2 I's. That is metastasis more than 10 millimeters. Stage 3A2, when you have microscopic extrapelvic peritoneal involvement with or without retroperitoneal lymph node involvement. Microscopic, so where is the metastasis here? So the omentum might look grossly normal, but on microscopic examination, it is positive for malignant cells. Then it is a stage A2 disease. Or your random biopsies taken in the peritoneum might be in the gutters of the abdominal cavity, and it will turn out to be positive, then that tumor is also a stage 3A2 disease. Stage 3B is macroscopic, so there is a gross lesion. Extrapelvic, above the pelvic brim, peritoneal metastasis 2 centimeters or less, with or without retroperitoneal lymph nodes, is stage 3B. Extension to the capsule of the liver or surface of the liver is also stage 3B. So if it is only capsule of the liver, it is stage 3B. On the other hand, if you have macroscopic extrapelvic peritoneal metastasis to more than 2 centimeters, with or without positive retroperitoneal lymph nodes, then it becomes your stage 3Z disease. So remember the size. So 3B is 2 centimeters or less. 3C is more than 2 centimeters. When there is extension to capsule of the liver, then it will be stage 3C disease. Okay, stage 4 or distant metastasis, excluding peritoneal metastasis, stage 4. Okay, stage 4 disaster. So this is a far advanced disease. So stage 4A, pleural effusion with positive cytology. So if there is only pleural effusion, but on cytologic examination, it does not contain malignant cells, then it is not a stage 4A disease. Maybe only stage 3 disease. So that pleural effusion should be positive for malignant cells. This is very important, especially here in the Philippines, because of the high incidence of pulmonary tuberculosis, which may present with pleural effusion. So they should not be mistaken as stage 4 ovarian cancer. Stage 4B is when you have hepatic and or splenic parenchymal metastasis. So here, the metastasis is not on the surface of the liver, but on the substance of the liver or parenchyma of the liver. So on palpation, you see that the tumor has invaded the inner part or the greater part of the liver. It is not only on the surface of the liver. Stage 4 is also metastasis to extra-abdominal organs, including your inguinal lymph nodes and lymph nodes outside of the abdominal cavity. So that is a stage 4B disease. So this is a graphic presentation of your stage 3 and stage 4 disease. So stage 3A, microscopic only. Okay, stage 3B, less than 2 centimeters. Stage 3C is more than 2 centimeters. Stage 4 is when you have parenchymal liver metastasis. If it is only in the capsule of the liver, so it is only a stage 3 disease, depending on the size. It can be 3B or it can be 3C. So 3B again is less than 2 centimeters, while 3C is more than 2 centimeters. So other major recommendations in the staging of ovarian cancers are your histologic type grading. So whether it is a well-differentiated or moderately differentiated or poorly differentiated, which we have previously discussed in cervical cancer also. The primary site of your tumor can either be ovary or the fallopian tube or the peritoneum, and it should be properly designated. Tumors that may otherwise qualify for stage 1 but involve the dense adhesions justify upgrading of the tumor to stage 2. So if you open up the tumor during exploration, you find that there are a lot of adhesions from the ovary to adjacent structure. It might be prudent to stage the tumor rather than stage 1 but a stage 2 disease. But histologic uh, proof should be established that there is a tumor in these adhesions as well. So how does your ovarian cancer spread? So there are 3 modes of spread of ovarian cancer. Okay, it can be coelomic, it can be lymphatic, or it can be hematogenous. Coelomic spread, that means the tumor spread through the peritoneal surfaces of both the parietal and intestinal areas. And maybe I forgot to mention that the lining epithelium that covers the ovary is the same lining of epithelium that covers the rest of the abdominal cavity, so that the abnormal cells from the ovary can spread through that lining epithelium, and that is called your coelomic spread. Okay, it may extend up to the diaphragm. Okay, the surface of the diaphragm, that is still considered as coelomic spread. Lymphatic spread, okay, spread to your lymph nodes. So para-aortic lymph nodes are at risk through a lymphatic spread. So you can have a common iliac or even your para-aortic lymph nodes. Hematogenous spread can also occur, especially exhibited by the presence of bone metastases. So this table shows to us the comparison between surgical findings of benign and malignant ovarian tumors. So it is the previous table I showed to you clinical findings. So now I am showing to you surgical findings. Okay, at the time of exploration. So when there are surface papillary growths, so they're common to be malignant. Intracystic papillae, also papillations or papillary growths within the cyst. Okay, it's very common in malignant ovarian tumor. Solid tumors, as mentioned previously, bilaterality bilateral tumors are commonly malignant. Presence of adhesions is common among malignant tumors, but you must also remember that adhesions is also common in endometriosis. The presence of ascites is malignant. Okay, your abdominal cavity contains peritoneal fluid. So if it is less than 100 milliliters or 100 cc, it is that commonly called ascites, but maybe just a normal amount of peritoneal fluid. So if it is more than 100 ml, 100 cc, that is called ascites, and it might be related to malignant ovarian tumors. The presence of necrosis within the cyst or in the surface of the cyst is again indicative of malignancy. Peritoneal implants is malignancy. Capsule is intact, more common among benign conditions, and if it is totally cystic, it is commonly benign. So based on your surgical findings, you can have an idea whether you are dealing with a benign or malignant ovarian tumor. So this is an example of an intraoperative finding of an ovarian tumor. So you will see that the tumor, the ovarian cyst, has a smooth capsule. Okay, so there are no papillary excrescences at the surface of the ovary. So it might be, if you follow the staging that we mentioned earlier, grossly, this might be a stage 1 disease because there are no papillary growths. However, when you open up the specimen, you will see that there are a lot of papillary excrescences inside. So grossly, again, the tumor is grossly malignant because of papillary excrescences in the surface internal surface of the ovary. So intraoperably, you can say that the tumor is probably or highly consider the possibility of a malignant ovarian tumor. Or it can be a far advanced disease, such as this one. So there are now implants not only on the ovary, but even in the omentum, or even in the surface of the liver, or even in the intestinal surfaces as well. So this is an advanced ovarian cancer, at least a stage 3C disease, stage 3B disease, at this stage 3B disease. So this is metastatic ovarian cancer. Okay, so now we go to stage distribution of ovarian cancer, as well as the 5-year survival rate. So most ovarian cancers are diagnosed late. Most of them are stage 3C at the time of diagnosis, and therefore they have a low survival rate, that is about 20%. So the earlier the stage, the higher is the survival rate, and the higher the stage, the poorer is the prognosis, the lower is the survival rate. So this is data from patients treated from 1990 to 1992. So we'll discuss about prognostic factors. So what are the factors that determine prognosis of patients with ovarian cancer? So again, as previously mentioned, in other type of gynecologic cancer, the most important prognostic indicator is the stage of the disease. The higher the stage, the poorer is the prognosis. Tumor grade, whether it is stage grade 1, grade 2, or grade 3, or well differentiated, moderately differentiated, and poorly differentiated. So poorly differentiated tumors has a poor prognosis. Well-differentiated tumor has a better prognosis. Cell type. So there are histologic type of ovarian cancer that is associated with poor prognosis. Among epithelial ovarian cancer, your clear cell and papillary serous has a poor prognosis. Whereas your well-differentiated mucinous tumor, early stage disease, has a good prognosis. Amount of residual tumor after resection. So the more tumors left behind after surgery, the poorer is the prognosis. So we always say that if you can reduce your tumor to less than, to the maybe zero residual after surgical intervention, the better is the prognosis of the patient, because that patient will also favorably respond to chemotherapy or an adjuvant treatment. So the more tumor that you leave behind after surgery, the poorer is the prognosis. So what are the adjuvant treatment used in ovarian cancer? Okay, so chemotherapy is the most popular. It depends on the stage, tumor grade, and histologic type. What do you mean by that? So stage 1A might not require a chemotherapy. However, if it is stage 1A, but grade 3, then it requires chemotherapy. Or even it is stage 1A, but clear cell type, it may need chemotherapy. So it depends on several factors to determine whether that patient would need chemotherapy. So epithelial ovarian cancer, the most common combination chemotherapy that you use is carboplatin and paclitaxel, or you can use carboplatin and docetaxel. For germ cell tumors and sex cord stromal tumors, usually it is combination of bleomycin, etoposide, and cisplatin, or vincristine, actinomycin D, and cisplatin. Radiotherapy has also been used for treatment in ovarian cancer. It has been used as a curative approach for early stage ovarian cancer, but not very successful in advanced ovarian cancer. Okay, so chemotherapy, with the advent of intensity modulated radiotherapy or IMRT, where the radiation is specific to the site of the tumor and you spare the normal tissues from radiation, then it might be helpful for early stage disease. Immunotherapy has also been utilized, okay, but it is still considered as investigative treatment, but currently there are more immunotherapy agents that has been developed, like your interleukin-2, your tumor necrosis factor. So later on, we might be using a lot of immunotherapy as well in ovarian cancer. So that is about epithelial ovarian tumors. So now let's go to germ cell tumors of the ovary. So again, germ cell tumors of the ovary among malignant ovarian neoplasms, they constitute about 20 to 20%, 25% of all ovarian neoplasms. So germ cell tumors are mostly benign. So 97% of germ cell tumors are benign. Only 3% are malignant. And germ cell tumors mostly occur in younger women, particularly in the second and third decade of life. So that is on starting more than 10 years old, okay, up to 20s. Again, emphasizing that germ cell tumor also is staged surgically, the same as your epithelial ovarian cancer. And there are certain histologic types that secretes a two specific tumor marker, which we will also mention later on, or I have already mentioned, I guess. That is your alpha-fetoprotein or your beta-HCG. So these are more markers for germ cell tumor. A single tumor marker may contain, a single tumor, may contain a mixture of different types of germ cell tumors of the ovary. So this is more or less a schematic diagram that more or less determine or tells us the different histologic types of germ cell ovarian tumors. So they germ cell tumors, as called, they arise from the germ cells of the ovary. So the major types are your dysgerminoma, and they're tumors of coming from your totipotential cells. So from these cells comes your embryonal carcinomas, okay, and your choriocarcinomas, endodermal sinus tumors, or those coming from the ectoderm, okay, your immature teratomas. So these are the different germ cell tumors. So again, this is the classification of germ cell neoplasms of the ovary. So you have dysgerminomas, endodermal sinus tumors, or yolk sac tumors of the ovary. You have your embryonal carcinomas, polyembryomas, and choriocarcinomas. Most ovarian tumors or germ cell tumors of the ovaries belong to the teratomas. And the most common, if you still remember your lecture on benign ovarian tumors, most teratomas belong to the mature cystic teratomas. So it is mature cystic is benign, okay? It is the immature component that is malignant, okay? Or it can be, your teratomas can be made up of monodermal or highly specialized cells. So where you have your struma ovarii, or you can have your carcinoid tumors, okay? Struma ovarii with carcinoid can also exist, or that introduce me to what you call mixed germ cell tumors. So in one tumor you might see it is germinoma with endodermal sinus component. So it might be embryonal carcinoma with this germinoma as well. So these are called your mixed germ cell tumors. So the treatment options for germ cell tumors, again, emphasizing that surgery is still the approach of treatment for germ cell tumor. Most or all ovarian cancer is surgery is the primary treatment. The extent of primary surgery in germ cell tumors is dictated by the findings at surgery and the reproductive desires of the woman. So that means how extensive it is tumor at the time of surgery, or if the patient is strongly desirous of pregnancy. So again, if you remember, I emphasized that germ cell tumors are found in younger women, and therefore maybe there is a strong desire to maintain the reproductive organs. So if it is a germ cell tumor and it is confined to the ovary, then unilateral salpingo-oophorectomy is the preferred treatment with preservation of fertility. Okay, so a woman who is strongly desirous of pregnancy, then a unilateral salpingo-oophorectomy can be performed, especially if the tumor is only found in one ovary. However, if the woman has already completed her reproductive potential, or the tumor is not only found in one ovary, but maybe in other structures, reproductive organs, then maybe a total hysterectomy with bilateral salpingo-oophorectomy should be performed. Chemotherapy has also been used in germ cell tumor. In fact, it was found that germ cell tumors are very sensitive to chemotherapy, and that is why unilateral salpingo-oophorectomy is already a good treatment associated with adjuvant chemotherapy, and they have excellent long-term survival. Some germ cell tumors are also radiosensitive, so especially your dysgermanomas are very radiosensitive ovarian tumors. However, because of conservation of reproductive function, radiotherapy is rarely used today, because generally when you use radiotherapy, there is exposure of adjacent structure to radiation, which might affect fertility of the patient. So we would rather use chemotherapy than radiotherapy. Lastly, we'll discuss about sex-cord stromal tumors of the ovary. So this type of tumor, ovarian tumor, arises from the ovarian matrix, and it consists of cells from embryonic sex cord and your mesenchyme. The incidence is quite rare or low, and they are mostly found among women in the 5th to the 7th decades of life. Approximately 90% of sex cord stromal tumors are hormonally active. That means they secrete hormones, particularly estrogen. Some of them also secretes masculinizing hormones. So these tumors are slow growing, and therefore they have good survival. Recurrence is commonly late. So management is, again, ovarian tumors are managed surgically. So surgery is adequate treatment in most cases. What we mean by that a unilateral salpingo-oophorectomy or total abdominal hysterectomy is enough. Rarely would we add chemotherapy unless they are advanced stage. So stage 1C or higher requires adjuvant treatment, either in the form of chemotherapy or radiotherapy. For those who are in the post-reproductive age group, then radiotherapy can be utilized. But in reproductive age women, and those who are desirous of pregnancy, then chemotherapy is commonly utilized. So either a unilateral salpingo-oophorectomy can be done in women who are still desirous of pregnancy, but those who have advanced stage and older women beyond age of menopause, then a total hysterectomy with bilateral salpingo-oophorectomy and tuber debulking should be properly done. Again, these are slow-growing tumors and they usually have a good prognosis. So I think we have discussed ovarian cancers, the different types, up to the different histologic types. So I would recommend that you read on additional cases like your tumor markers, the utilization of scoring systems. So please review. And also I included in this PowerPoint presentation some exercises which you can try to answer, or which we can answer during the synchronous activities that we're going to have in relation to ovarian cancer. So thank you very much, and I hope that you learn something today about ovarian cancers. Thank you and goodbye.